This is going to be Chapter 1, Introduction to Pharmacology. And one of the most important aspects of EMS is a thorough patient assessment. In that patient assessment, we must determine scene safety, chief complaint, what occurred prior to the chief complaint that actually got us there, airway and circulatory status, level of pain, and everything that is required to treat our patient appropriately from patient interaction. We must attempt to determine medication that the patient is currently taking. That includes the last time they took it, dosing, if there's any complications between medications. If we fail to do this, then the receiving facility is going to have to start from Jump Street or start over from scratch. So it's very easy for us, since we are there and we're obtaining the history and we're acquiring the medications, to actually get them something so that they can initiate treatment. Disease precautions. So precautions against pathogens and disease. And it's pretty hard to determine whether or not someone is infected with a bloodborne infection. The Center for Disease Control kind of suggests that we use standard precautions, or they do suggest that we use standard precautions on everybody. And standard precautions are infection control precautions that healthcare professionals should apply with all patients in all situations. We should do this through the use of body substance isolation. And body substance isolation should be used when, and this would be things like protective wear, gowns, gloves, masks, and so on, depending on scale up or scale back procedures, depending on what we think the infection is. We should always be safe and prepared, though. Healthcare professionals should wear gloves when performing procedures such as starting IV lines, drawing blood, giving injections, inserting endotracheal tubes, and so on. Whenever possible, healthcare professionals should use disposable equipment. Once used, properly dispose of the equipment. Do not recap, bend, break, or remove needles from the syringe. Dispose of the needles and disposable syringes in a designated puncture-resistant container immediately after their use. Precautions against bloodborne pathogen and infectious disease. BSI, or body substance isolation, is a practice of isolating all body substances, blood, urine, feces, tears, etc., of individuals undergoing medical treatment, particularly emergency medical treatment of those who might be infected with illnesses such as HIV, hepatitis, so as to reduce as much as possible the chances of transmitting these illnesses, because you do not want to take these home. Standard precautions, and this is figure 1.1, are things like bodily fluid contact, washing exposed areas, properly dispose of the mask and gown, disposable equipment if possible, and take appropriate precautions against all bloodborne infections. Medical assessment, and this would be the assessment where we are determining what all kind of medications are in play. Now, very simply, sometimes the patient doesn't even know their own medical history, and from looking at their medications, because we'll know what these medications are for, or if you come across a medication that you've never seen before, look it up so that you know what kind of disease it's generally given for. That can give us a wealth of knowledge. It's a part of every patient assessment. It provides important information. Failure to obtain delays the treatment, because essentially the receiving facility has to start over at Jump Street. And the consequences of us not doing this can delay treatment drastically. Usually the patient for this is the best source of information. There's also things like the vial of life, home health aides, medication assessment questions whenever we're asking them. This goes in a little bit deep, but this is a good starting point. Things like, what kind of medications are you currently taking? Do you know what the names of those medications are? Some people cannot. So go and look in their bathroom with their permission to see where they keep their medications so that we can get it from the bottle. When did you take your medications last? Have you been taking your medications according to prescribed directions? Are you taking any over-the-counter medications? Because they can mix and match things like cough syrups with high blood pressure medications and get untoward effects. Are you taking any herbal preparations? Are you taking any medications that were prescribed for someone else? Have you recently completed taking your medications? If so, what were they? Have you experienced any side effects or illnesses from your medications? One last thing to do, take a look at the medications whenever you have the bottle. they may have additional information on them. An example of this is swallow whole, do not crush or chew, take on an empty stomach. So if the patient says, yeah, those things taste horrible, I've been chewing them up, that might lead you, it increases the chances of them having one of the more aggressive side effects and an untoward effect. Do not discontinue or skip doses unless directed by your doctor, may cause drowsiness, and so on. So take a look at their medications. The patient's generally the best source for this information, but if they can't quite give you all the information that you're looking for, kind of be a detective in that aspect. History, trends, and pharmacology. Historical trends in pharmacology, evil spirits inhabiting the body and causing diseases. The belief continued until about 460 BC when Hippocrates, known as the father of medicine, concluded that disease resulted from natural causes and could only be understood through the study of natural laws. Hippocrates believed that the physician's role in healing was to assist the body's recuperative powers. Roots in pharmacology go back to ancient civilizations which used plants and plant extracts to treat illness and cure disease. Examples of these are going to be opium and morphine, foxglove extracts and digitalis, Jesuit's bark used to treat malaria, willow bark for treating fever, extracts of the poppy plant or opium for dysentery. Historical trends continued. Pharmacology continues to advance based on the knowledge gained from ancient civilizations. The oldest known prescriptions were found around 300 BC on papyrus tablets. In 1240, Emperor Frederick II declared that pharmacy was to be a separate science of medicine. It was not until the 16th century that Valerius Cordus authored the first pharmacopoeia, or drug reference book. Modern healthcare. Consumer health education has motivated the public to take more responsibility for their health and disease prevention. More people are now regularly on an exercise program and are paying more attention to what they actually eat. Many people are using the internet sites such as WebMD and Medline for personal disease self-research. Drug companies are now advertising directly to the consumer because of this. Pharmacology has become multidisciplinary. Chemistry, genetics, immunology, microbiology, pathology, and physiology. During the past few decades, there has been remarkable progress in developing new drugs and understanding how they act in the body. Research is directed towards new treatments, cures, or methods to prevent disease. The Orphan Drug Act was signed into law in January 4th, 1983. An orphan drug refers to a product that treats a rare disease affecting fewer than 200,000 Americans. The intent of this act is to stimulate research, development, and the approval of products that are treatment for rare diseases. Definitions. Drugs. Any substance when taken from the body changes one or more of the body's functions. And pharmacology, which is the science of drugs, including the study of their origin, ingredients, uses, and actions in the body. Pharmacokinetics, the movement of a drug in the body with particular emphasis on its distribution, how it gets around, its duration of action, how long it's going to stick around, and its method of excretion, when it's going to get out, and what method it's going to take to get out. Pharmacodynamics, the study of drugs and their actions on body tissues. So how this drug actually interacts with the body tissue and what it does, if it makes an active metabolite or if it just goes directly to the receptor. Pharmacotherapy, the use of drugs in the treatment of disease. Toxicology, the study of poisons and adverse drug effects. Pharmacogenetics, the study of the influence of hereditary factors on the response to drugs. Examples of this would be Native Americans, African Americans, Asian Americans, and so on. All of these genetical factors could come into play when a specific drug is given to a certain populace. Drug names. Whenever we look at drug names, we come up with about 4 of them. Now, every drug has essentially 4 names, and this is going to get complicated at the point that you're putting this into memory. First of all, it has a chemical name, and this is one we generally don't use too much. So triethylmethyl 3 hydroxyl whatever, we do not identify the drug generally by this. A chemical name identifies the drug's chemical structure. The generic name we use quite often, usually an abbreviated version of the chemical name. The trade name, and this is the one given to the drug by the manufacturer. An example of this would be furosemide versus Lasix. Lasix, it would be the registered trade name, where furosemide would be the generic name for that. And then, last but not least here, we have an official name, which is published by the United States Pharmacopoeia. And this is to identify that it is a registered drug within the United States. And it is the official drug reference of the United States. An example of this, if we had a drug, furosemide USP would state that that is the official name that was logged into the United States Pharmacopoeia. Plant sources of drugs. Oldest source of medications includes the entire plant, leaves, roots, bulbs, stems, seeds, buds, and blossoms. Recent understanding seeks to source and isolate active components, and alkaloids are the largest group of active components. Organic alkaloids react with acids to form a salt and are more readily absorbed in the body. The name of the drugs end in INE. An example of this would be Atropa belladonna, nightshade, or atropine. Opium plant, morphine, purple foxglove, digitalis. And these are this is belladonna, so this one here is atropine. This one here is digitalis, or digoxin. And then this one here is a poppy plant, or opium. Animal sources of drugs. Bodily fluids or glands from animals. Sources includes hormones, oils, fats, enzymes, which act as catalysts. Examples of hormones, insulin and oxytocin. Oils and fats would be like cod liver oil. Enzymes would be pancreatic and pepsin. Vaccines, suspicion of killed, modified, or tweaked or attenuated versions of the actual thing that we're vaccinating against. Examples of this would be smallpox. Mineral sources of drugs. Metallic and non-metallic minerals provide various inorganic materials not available from plants or animals. Mineral materials are used as they are or combined with other ingredients to yield acid, bases, or salts. And examples of this are sodium bicarbonate and magnesium sulfate. Bicarbonate is used to treat metabolic acidosis, and mag sulfate is used to treat eclampsia. Laboratory-produced drugs. Many newer drugs today are commonly produced in labs. Can be natural, animal, or plant, synthetic, or a combination of both. Examples of these are things like thyroid hormone, cimetidine, anastrozole, insulin, which is recombinant DNA, lidocaine, absolutely synthetic, bertillum tosylate or bretolol, and diazepam or Valium. Drug classifications. There are many drug classifications. Things like adrenocorticoid, alpha-1 adrenergic blockers, aminoglycosides, antidysrhythmics, and their multiple groups. There are 4 classes of antidysrhythmic. Anti-diabetic drugs. All of these classifications, it would be my suggestion to you to learn them by the classifications. Each one of these drugs are going to have a prototype drug. And what we learn from the prototype drug is that it has all the cellular interactions that all of the rest of the drug in that category have. An example of this, a group 1 or class 1 antidysrhythmic, the prototype for that is lidocaine. So from lidocaine, we learn of its interactions and the things that it does. A group 1 is a sodium channel blocker. So that means that all of its cousins will generally interact the same when applied to the cellular environment. Drug classifications continued. Antidotes, antipsychotics, corticosteroids, diuretics, emetics, histamine 2 or H2 blockers, calcium channel blockers. hydrogen ion buffers, inotropes, vasodilators, vasopressors. All of these, start looking at them now so that you understand what these drugs do generally, so that you can start applying previous knowledge or scaffold your information, so to speak. Drug forms, liquid. We have solutes, which are powders dissolved in liquids, and we have solutions. So very simply, a solution is nothing more than a solute that's been put into fluid, and now the two parts are mixed together and it is a solution. Tinctures are drugs that are mixed with alcohol. Suspicions are drugs that do not remain dissolved. An example of this would be like amoxicillin suspension, the pink stuff that they give kids for otitis media or ear infections. The suspension pretty much says shake well before giving it to your kiddo. Well, that's because whenever you put it in the icebox or refrigerate it, it separates out. So the drug is actually a little bit heavier in there, or the solute is, and it'll kind of go to the bottom. So by shaking it well, you mix all those parts per million up. Spirits, solutions that contain volatile chemicals. An emulsion is drug mixed in an oily substance. Elixirs, drugs contained in alcohol. So dimetap elixir is going to be in alcohol. A syrup is a drug suspended in sugar and water, so a drug suspended in syrup. Administration of liquid drugs. We have parenteral drugs administered through intramuscular, subcutaneous, and intravenous routes. A parenteral route is defined as any route other than the alimentary canal or the digestive system. And this is packaged in vials, ampules, and syringes. Drug forms, solids. Solid drugs are usually administered orally, but may be administered rectally. Examples of this would be pills. Everyone knows what a pill is. Drugs shaped in the form that are easy to swallow. Or powders, drugged in powdered form. Not very popular now, but they used to be. They still have those aspirin powders that you can mix. Capsules, gelatin containers, which hold drug powder in them. And then tablets. Powdered drug is compressed into a specific shape. Drug form, suppositories, and administered rectally or vaginally. Carry medication in a solid base that melts at body temperature, dissolved, and is absorbed in the surrounding tissues. Various types of this are things for analgesia. We can use them for laxatives, anti-infective, antiemetic, and antipyretic. So anti-fever, anti-vomiting, anti-infective at the point that we're looking for, let's say, vaginal suppositories that would decrease yeast, laxative, and then analgesic effects or painkillers that we can put or give via suppository. Drug form, inhalants, powder or liquid form of the drug that is given through the respiratory tract. This is absorbed rapidly by a rich supply of capillaries in the lungs. The lungs are highly vascular. And methods of delivering this are going to be via nebulizers or the metered dose inhalers, rescue inhalers that asthmatics carry, or vaporized, like you could put medication in a vapor of some sort, a more aromatic version of nebulization. A nebulizer kind of keeps it isolated into one area so the drug is more concentrated. Drug research and marketing. Pharmaceutical companies are pretty motivated to bring profitable drugs to the market. The process after development to the market normally takes from 3 to 17 years. Now that's an awful long time. Transition times. Research and development, preclinical testing, 1 to 3 years. Clinical research and development. That means that we're going to look at its toxicity, the absorption, the therapeutic index, ratio of lethal to therapeutic dose. And that's about 2 to 10 years. New drug application and review by the Food and Drug Administration, 2 months to 7 years. So in this we get phases. So in phase 1, determine the drug's pharmacokinetics, that's onset, peak, and duration, and it's toxic and safe dose to humans. So whenever we're looking at toxicity or the therapeutic dose, and that would be the next level of this, we pretty much, as far as the drug, take a look at this right here. So the drug onset and peaks and we want it to do this. Now, during this time frame, whenever it's in this zone, it is therapeutic, or it's doing what we want it to do. However, if we get too much of the drug, this level of drug in the body, here at the upper level of it, probably has an LD50 rating, which means it killed 50% of the lab rats. So that's how they determine the toxicity, is they figure out how many parts per million of this drug in the system would be toxic or cause death. Now, in phase 2, they find the therapeutic drug level and watch for careful side effects. So anything that's weird, this is where they come up with their side effects, what the minimal amount is, what the maximum amount is, and then they go to phase 3. And they usually refine their therapeutic dose and collect relevant data on their side effects. So is this doing anything weird? Does it have untoward effects? Those untoward effects I need to be able to identify. Does it have any side effects? Does it have any adverse effects? Does it interact with other medications badly at this level? So all of those things need to come into play whenever we're giving it to the populace, because they could have a multitude of different medications on board. Phase 4, post-marketing after conditional approval from the FDA, the drug maker monitors performance in general population usage. So once they first start getting information back from the populations, is this going to be a good drug or not? Expedient drug approval still goes through all 4 levels with a shortened process, usually used on drugs where diseases pose a threat to public health. Approval is applied for whenever phase 2 is reached by the manufacturer. This would be things, probably there were some drugs that had expedient drug approval as far as HIV. Orphan drugs, drugs that may be useful in treating various diseases but have a limited market and a high cost of research and development. And in 1982, the government came up with the Orphan Drug Act. It offered substantial tax credits to companies that developed orphan drugs for rare diseases. Because of this, many patients now use drugs that until recently remained unavailable because there just wasn't enough profit in making that drug for a specific amount of population that drug would help. Black box warnings. If the use of the drug leads to the death or serious injury, the FDA may require the manufacturer to post warnings in a prominent position on the label. Unlabeled use of drugs. The FDA accepts the uses for a new drug that were indicated in which phase 2 and 3 clinical testing showed it to be safe. All other uses are not approved and called unlabeled. A drug profile. This is what your drug profiles will be for your homework. I need the names and all of them. When I say all of them, at least the generic name and the trade name. Occasionally reference the chemical name on specific drugs. Example of this would be sodium bicarbonate. Therapeutic classification, broad group in which the drug belongs in, and that's the ones that we talked about in the previous slides, to where an alpha-1 agonist would be a therapeutic classification. The mechanism of action, the way that the drug causes its effects, what it actually works on and what it actually does. A simple version of this will be fine. Therapeutic benefits describes the results expected when the administration of the drug occurs. So the therapeutic benefits of, say, epinephrine say we're using epinephrine for anaphylaxis, solves the hypotension, decreases the signs and symptoms of the urticaria, closes my leaky system, decreases airway swelling, so on, ... Pharmacokinetics, how the drug is absorbed, distributed, and eliminated. The indications, the conditions for which you need the drug. Example again, epinephrine, anaphylaxis. It has multiple uses, though, besides just anaphylaxis. Contraindications, circumstances under which it should not be used or whenever an alternate drug should be considered. Precautions, situations in which the drug may be actually dangerous. Side effects and adverse reactions, untoward reactions or reactions that we were not expecting, or reactions other than the desired. Routes and dosage, how you give it and how much, and EMS considerations and how supplied. Any kind of special considerations for special patients that we might come across, and the common concentrations that it comes in. And that would be a drug profile. Legal regulations, standards, and legislations. We have several of them. Let's start talking a little bit about the Pure Food and Drug Act of 1906. It was the first U.S. law to protect the public from mislabeled poisonous or harmful drugs. The Harrison Narcotic Act of 1914, legislation designed to stop drug addiction. It established federal control over important manufacture and sale of opium and cocoa plants and their compounds and derivatives. The Federal Food, Drug, and Cosmetic Act of 1938 updated the Pure Food and Drug Act legislation and required that manufacturers label any habit-forming products. And then the Comprehensive Drug Abuse Prevention and Control Act of 1970 supersedes all other narcotic acts, classified drug potentials for abuse, and no acceptable medical usefulness. So this classified them as this does have some medical uses, this does not have medical uses, and so on. Pure Food and Drug Act of 1906, talked about that, established by the FDA, prohibited the sale of medicinal preparations that had little or no use, named the United States Pharmacopoeia, USP, and National Formulary as official drug standards. The Schedule of Controlled Drugs, a Schedule 1, has a high, and this is what occurred in 1970, has a high abuse potential with risk of severe dependence and has no medical use. A Schedule 2, high abuse potential with risk of severe dependence, some medical indications. Schedule 3, moderate abuse potential with risk of moderate to low physical dependence and or high psychological dependence. Schedule 4, low abuse potential with limited risk of dependence. And Schedule 5, lowest abuse potential with limited dependent risks. Drug standardization. Strength of drugs may vary considerably. Must be uniform strength when offered to the market. So it needs to be standard all the way across the board. Drug ingredients may be unknown, or active ingredients may be unknown. Official Book of Drug Standards in the United States is the United States Pharmacopoeia. Special considerations. Age, pregnancy, and lactation. Both children and elderly are particularly susceptible to this. Drug dosages are often modified for persons that have these special considerations. Pediatric patients. Children are smaller than adults, and dosages must be adjusted accordingly. Pediatric dosages are typically based on the patient's weight or body surface area. Methods for calculations are the American Heart Association published recommended drug dosage based on weights and BSA. And a Brownslow's tape is a color-coded device that we can use on a supine child and measure out what the appropriate color code for that child is. And in that color code, an example of this would be this child is color code pink, it would have the appropriate dosage. Geriatric patients. Elderly age group is the fastest growing segment in the U.S. population. Baby boomers are getting older every day. Older adults are frequently users of the healthcare system. Seniors are more apt to suffer from one disease process at a time, so they may have multiple diseases. Common physiological effects of the elderly in general: decreased cardiac output, decreased renal function, decreasing brain mass, decreasing total body water. They can get dehydrated more frequently. They can concentrate their drugs more easily. Decreased body fat, decreased serum albumin, which we're going to learn in later chapters, give us the ability to biotransform some of the drugs. Decreased respiratory capacity, and decreased metabolism. Pregnancy and lactation. Pregnancy presents two pharmacological problems: number of anatomical and physiological changes to the mother. The mom itself has an increased cardiac output, increased heart rate, and blood volume up to 45%. Decreased protein binding, decreased hepatic metabolism, and decreased blood pressure. Any medication administered to the mom has the potential to cross across the placenta and affect the placenta, some more rapidly and others do not at all. Many medications affect breast milk and are excreted readily from the mother to the infant. The mother should discard the milk until the drug clears the system. Conclusion. Administering drugs is a part of EMS care. EMS professionals are held responsible for safe and effective drug administration. EMS provider are responsible legally, morally, and ethically for each drug administered. And you must be familiar with the drugs used in your local EMS system. The knowledge of each drug's actions, indications, contraindications, side effects, precautions, and correct dosage, and the route given, and any pertinent interactions is essential. References for this slide set were taken from Beck Pharmacology for the EMS Provider, Delmar Learning, pages 1 through 20, and Bledsoe's Pre-Hospital Emergency Pharmacology, 7th edition. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith. I'll be reached at smithr@imsa.net or 405-219-7613. Thank you.